Welcome to our live webcast, The Changing Paradigm of Amyloidosis Treatment. Thank you for joining us. My name is Mike, and I'll be the operator for the presentation today. Before we get started, I'd like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. During this presentation, you will see the following multiple-choice polling questions during the event. To participate in the polls, please select the buttons or just to the left of the answer that best represents your views or experiences. On the right-hand side of your screen, you'll see the text chat window. There's a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. Send a question, click in the text box and type your text. When you're finished, click the send button. All questions that you submit are only seen by today's presenter. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we will ask that you complete a brief post-event survey. Please take a moment to complete this survey as it will help the Amyloidosis Foundation plan future web events. And this time we are joined today by our speaker, Dr. Jeffrey Zonder. Dr. Zonder is a professor in the departments of oncology at the Barbara Ann Karmanos Cancer Institute and Wayne State University School of Medicine. He is the leader of the KCI Myeloma Multidisciplinary Subteam, medical director for Karmanos Cancer Center Therapeutic Apheresis Unit, a medical advisor for the Amyloidosis Support Group Networks, and a member of the International Myeloma Working Group, the International Myeloma Society, and the International Amyloidosis Society. He received his medical degree from Wayne State University School of Medicine. He completed his medical residency at the University of Rochester in Rochester, New York, before returning to Wayne State University for Hematology Oncology Fellowship training. He is a member of the American Society of Hematology, the American Society of Clinical Oncology, the American Medical Association, and the Swag-Barlogi-Salmon Myeloma Committee. Dr. Zonder has authored or co-authored numerous original research papers, review articles, book chapters, and research abstracts on myeloma and amyloidosis. This webinar will last approximately 40 minutes, and we will have time for your questions at the end. The Amyloidosis Foundation would like to thank Alnylam Pharmaceuticals for sponsoring the webinar today. After the webinar, you will receive an evaluation via email to complete. We appreciate you sharing your thoughts about the webinar and what topics we can offer in the future. The webinar will also be available shortly on the Amyloidosis Foundation website for future reference at www.amyloidosis.org. And again, thank you for participating today, and let's welcome Dr. Zonder.
Hi, this is Dr. Jeffrey Zonder from the Karmanos Cancer Institute in Detroit, Michigan, and I want to welcome you to today's presentation. Thank you so much for tuning in to listen to this lecture about the changing paradigm of amyloidosis treatment. I'd like to especially thank the Amyloidosis Foundation for arranging for this program. These are my disclosures. I serve as an advisor to several companies which make products which will be discussed today, and I'm sharing these for your information. Today, I plan to cover a lot of ground. First, we'll discuss a general overview of amyloidosis and the symptoms that people may experience when they're first diagnosed. We'll also talk about the diagnostic workup, and we'll talk about specific subtypes of amyloidosis with a focus on AL, or light chain amyloidosis, and ATTR, or transthyretin amyloidosis. And we're going to really specifically explore the importance in making the correct diagnosis, specifically identifying the actual subtype of amyloidosis and why that's important when selecting treatment. Finally, we'll talk about emerging therapies that target amyloid fibrils and amyloid-forming protein in the context of these two specific types of amyloidosis. First, what is amyloidosis? Really, it's a group of diseases There's over 30 different types, but what they're all characterized by is the presence of misfolded proteins that form fibrils or strands that are deposited in body tissues. And we classify the different types of amyloidosis according to the protein subunits that make up those strands. And the symptoms that a patient has usually depends on which organs are affected by the amyloid fibrils. This slide is sort of meant to illustrate the fact that there are so many different types of amyloid, and you can see that the top one listed here is AL amyloidosis, and a few spaces down there's ATTR amyloidosis. And I'm using this one to highlight the fact that there's a lot, but also as a segue into this, which explains the nomenclature for amyloidosis. So all the different types of amyloidosis are abbreviated with a system that starts with A for amyloid, and then some other letter or letters to abbreviate the protein subunits that are causing the amyloid. So in the case of AL, the L stands for light chains. In ATTR, the T, T, and R stand for transthyretin. In AA amyloidosis, which is a type that we don't see very commonly anymore in the United States, the second A stands for aposerum amyloid A protein. So we have AL, ATTR, AA. And the question is, how does a clinician or a pathologist tell these apart from a biopsy? Well, the first thing we do when we do a biopsy is we do a special stain called Congo red staining. Congo red staining, what you can see here, this is a glass slide that has a kidney biopsy on it. And when you apply Congo red stain, the amyloid appears pink. And then when you look at those same pink areas under a polarized light, they look fluorescent green as shown here. Then there's additional testing one can do using laser microdissection, and you can actually cut that area of amyloid off the slide, and then you can feed it through a machine called a spectrometer. You can do tandem mass spectrometry, and you can distinguish the type of amyloid by doing this chemical analysis of it. So the first step is a biopsy. The second step is Congo red staining to confirm there's amyloid in the biopsy. The third step is chemical analysis of the material identified, and mass spectrometry. Mass spectrometry is the most commonly performed type. Occasionally, you can do additional stains. You can do something called immunoelectron microscopy or other techniques to identify the type. But the type shown here is increasingly the most common methodology for distinguishing the type of amyloid. First, we're going to talk about AL amyloidosis, and this is a plasma cell disease. Plasma cells are normal cells that are in our bone marrow. They're part of our normal immune system, and normally they make up 1 to 2% of the cells in our bone marrow. And in a normal situation, we have an equal number of two different types of plasma cells. We'll call them kappa plasma cells and lambda plasma cells. Plasma cells' job is to make antibodies, and the antibody that a plasma cell makes contains a fragment called a light chain that is either a kappa light chain if it's a kappa plasma cell, or a lambda light chain if it's a lambda plasma cell. And in fact, there are also small amounts of free-floating light chains in our blood, and we can measure that using a test called the serum free light chain assay. We're going to come back to that in a little bit. But suffice it to say that normally in the bone marrow, there's an equal number of kappa cells, kappa plasma cells, and lambda plasma cells. And we call this situation polyclonal, meaning there are several different clones of plasma cells. Now, AL amyloidosis is a monoclonal plasma cell disorder. And what that means is one clone sort of overgrows or over-proliferates compared to the other clones and becomes more dominant. And in the example that I'm showing in this slide, one of the lambda plasma cells starts proliferating, and you can see that more of those daughter cells from that original cell are produced. And when you add up all the kappa and lambda plasma cells, now there's an excess of lambda plasma cells. And you can see that the ratio has increased from 1 to 1 to 1 to 3 in this situation. So what does this mean? Well, before we go there, let's talk a little bit about antibodies. And remember I mentioned that antibodies are what plasma cells produce, and they produce them to fight infections or other foreign things in the body. And you can see here, I put in the inset a picture of a barbecue fork, and we know what the business end of a barbecue fork is. And I think you can see from this cartoon that there's a corresponding business end to the antibody, and that's the end that binds to something specific. And you can see that the plasma cell is comprised of 2 heavy chains, which are blue, and 2 light chains. And both of the light chains on any given antibody are there's either 2 kappas or 2 lambdas. And again, the kappa or lambda depends on what the nature of the plasma cell that made it. Kappa plasma cells make antibodies that have kappa light chains. Lambda plasma cells make antibodies that have lambda light chains. And the question that I'm asking in the inset is it more like a barbecue fork, or is it actually more like a key? And it's kind of a little of both. So I'm showing you the business end, but it's not an indiscriminate pointer like at the point like at the end of a fork. It plugs into something more like a key, and so it gives antibodies specificity against a certain something. So that's how antibodies against one type of infection will fight that infection, but it won't fight other infections. It has to do with the sort of the configuration of the business end of these antibodies. Now, again, in addition to the light chains that are part of antibodies, there are also light chains that float around in our blood. Normally, these light chains are produced. They're at low levels. There's an equal number of kappa and lambda light chains, and they float around in our blood after being produced by the plasma cells and are eventually either degraded or flushed out of our system in the urine. So there are low levels of detectable antibodies in both, light chains rather, in both the blood and in the urine. Now, in amyloidosis, what happens, AL amyloidosis, what happens is that the abnormal plasma cells make abnormal light chains, and these light chains misfold, and they form small clumps that are still soluble in the blood. We call those oligomers. And then after that, those start coalescing into fibrils, which actually aren't soluble anymore in the blood, and those deposit in the tissues. And there's lots of evidence to show that the symptoms people have to do with the combination of both the toxic clumps that are still floating around in the blood and also the deposits of fibers in the tissues themselves. Now, when we measure free light chains in the blood, actually all we're measuring are the non-clumped light chains that are in the blood. But we can deduce that there are elevated levels of these other forms in the blood when the levels of the light chains, the free light chains in the blood are in fact elevated as well. So in AL amyloidosis, because there's an excess of one type of plasma cell or the other, either the kappas or the lambdas, what we see is an excess of the corresponding light chain. And so a person with lambda light chain amyloidosis, which is shown in this example right here, we're going back to the example that we had before. What we see here is if we do several measurements of the light chain levels in this person's blood, what we'll see is that there's an excess of lambda light chains compared to kappas. And you can see that the the measurements skew away from that dotted line, which goes diagonally up the middle, which is the 1-to-1 ratio. Our therapy strategy in AL amyloidosis has basically been to try and reduce the number of plasma cells that are producing light chains. And when you do that, you restore that normal 1-to-1 ratio again. And as you do that, if you follow the light chain levels, as you're giving treatment that lowers plasma cell numbers, you see the light chains start to come down as well. And that's how we know that treatment has been effective. We know that the abnormal misfolded light chain levels come down in the blood, and the relative ratio, or the difference between the involved, in this case lambda light chains, versus the normal light chain, in this case the kappa light chains, comes back down to 1-to-1. Now, as I said before, the symptoms that somebody has in amyloidosis depends completely on what organs are involved, and it's not the same for everybody. So we can see here several pictures. In the top picture, we see somebody's tongue with deposits of amyloid in it, making it swollen. Sometimes instead of having these nodular areas, what happens is the tongue just becomes generally enlarged, and that's pretty specific for AL amyloidosis. The middle picture is a kidney biopsy, and the pink area that you see right here, as well as the pink rims around here, this is actually the area of amyloid. And in the bottom picture, we have a picture of somebody's heart. And just to orient you, I did this animation, which shows you, you're looking straight down through the heart, cut in cross-section. And I think it's easy to see here that the walls of the heart here are extremely thick, including this area right here. We'll come back to how we assess heart involvement in a little bit, but the tongue, kidney, and heart are definitely not the only organs that can be involved. Other common organs include the nerves, and usually that you get a numbness or tingling in the fingertips and toes, but sometimes you can get carpal tunnel syndrome as a different form of nerve involvement, or autonomic nerve involvement, where the nerves that affect things like your blood pressure and your gut motility and your heart rate, those can become involved. Not as common, but when it does happen, it can cause a lot of symptoms. Finally, the gastrointestinal system can become involved, and when that happens, diarrhea and inability to absorb food normally becomes a potential problem for patients. So, of all the organs, as you might suspect, heart involvement carries the most significant implications for prognosis. If the heart is heavily involved by amyloid, patients are at risk not just for congestive heart failure due to the thickening and stiffening of the heart, but also at risk for electrical conduction problems and fatal heart rhythms. And so you can look at sort of mechanical aspects of this with an echocardiogram and do things like measure the intraventricular septal diameter, as shown here, and I sort of labeled that. That's basically the thickness of the wall between the bottom chambers of the heart. But a more reliable and reproducible thing one can do is do some blood tests, including a measurement of troponin and something called NT-proBNP. And there are staging systems, two different versions of the same staging system that have been done at the Mayo Clinic, created at the Mayo Clinic, which takes into account these different cardiac markers in the blood, and basically we stage patients based on whether one is abnormally elevated, both are abnormally elevated, or neither is abnormally elevated. And by doing that, we can basically break people into stages 1, 2, and 3. The newer version of this actually also incorporates the free light chain levels that I mentioned before into the staging system, and so it's a 4-stage staging system. But the point is that prognosis is affected by heart, and you don't need to know anything else about the patient to be able to sort of categorize the patient into a standard higher and highest risk group. So as I mentioned before, the goal of therapy is to induce the deepest, longest light chain reduction possible. Because remember, those abnormally folded light chains that we're measuring with the serum free light chain assay are what go on to form those toxic clumps and strands. And so by choking off production of these subunits, you don't get those downstream toxic deposits. As we're lowering the light chain levels, it's important to remember that the symptoms a person has are often going to be lasting, because the symptoms they have are from damage that's already been done to the organ. And so multidisciplinary management is a very critical part of the initial management of amyloidosis. A hematologist, oncologist might be the person administering therapy to lower the light chains, but any damage that's already been done to the heart, the kidneys, or the nerves, or other organs should be managed on an ongoing basis by specialists who work in those areas. And it's also really important for patients to understand that although organ function can improve, it's most likely to improve if you get a good light chain response. And it's also highly likely to improve long after the light chains go down, even if it improves at all. So you're trying to get a deep response to really choke off the source protein that forms amyloid, but you also want a long response so that it gives your body a chance to actually start cleaning up the mess from the original amyloid deposition. And there's lots of data now to prove that this really matters. So this is a graph of a bunch of patients with survival measured over time based on how the patients responded to initial therapy. So everybody on this graph got several different months of therapy, and these patients are not divided up according to cardiac stage or anything. It's just a group of patients, and the way they're divided up is how deep of a response did they get? Did the light chains go down at all? If they didn't, that's no response. If they went down by about half, that's called a partial response. If you're able to get the difference between the involved or amyloid-forming light chain and the other light chain down to a difference of 4 milligrams per deciliter or less, we call that a very good partial response. And if you can totally normalize the light chain, we call that a complete response. So these are basically just varying degrees of suppression of the involved light chain, ranging from no suppression to complete suppression. And what you can see is that the deeper the response, the better the survival for the patients. And the reason for this is that there's less ongoing injury to the organs over time if you're able to shut down production of amyloid. So how do we choose therapy? Well, the therapies that we use are really derived from the treatment of multiple myeloma. So myeloma is a plasma cell cancer. And even though amyloidosis is not cancer, we use these same therapies to kill the abnormal amyloid-forming plasma cells, like we use them to kill the cancerous plasma cells in multiple myeloma. And historically, there are 4 basic classes of medications that are sort of in heavy rotation. The oldest ones are the ones on the right, the alkylators and steroids. And actually, like melphalan and prednisone, or melphalan and dexamethasone, those have been in use since the 1980s. And those would be considered the original standard therapy for amyloidosis. And it should be noted that melphalan, when used as high-dose therapy. When you give it, instead of giving low doses orally every several weeks, you can give one big high dose of melphalan, and that's actually the prep regimen before an autologous stem cell transplant. So if you wanted to use a high dose of melphalan, you have to collect somebody's stem cells ahead of time and store them out of harm's way. Newer therapies include the immunomodulatory drugs, which are on the far left, and proteasome inhibitors, such as bortezomib, which is in the blue column. And actually, bortezomib specifically has emerged as a very important therapy in AL amyloidosis. Just as melphalan can be combined with steroids, so can bortezomib, and there's very good data about using bortezomib and dexamethasone as therapy for AL amyloidosis. But probably, though, the best way to use these agents is to combine bortezomib, an alkylator, and a steroid together. And the most commonly used regimen is one called CyBor-D, and CyBor-D is an abbreviation for Cytoxan, bortezomib, and dexamethasone, CyBor-D. There's also data about combining melphalan, bortezomib, and dexamethasone, and that's actually in the process of being compared in a head-to-head study against melphalan and dexamethasone alone without bortezomib over in Europe. And what we know so far is that overall response rates when you use 3 drugs together rather than 2 drugs together seem to be higher. But the decision between 3 drugs versus 2 drugs, or high-dose melphalan versus standard-dose melphalan, these kinds of decisions are made after conferring with the hematologist oncologist and sort of considering whether or not a particular patient can tolerate the side effects related to a particular regimen. The immunomodulatory drugs on the far left are often not used as part of frontline therapy in AL amyloidosis, although they are in multiple myeloma. In amyloid, because they're not tolerated quite as well, they tend to be used as second or third line therapy if somebody needs treatment after having been treated with one of these more commonly used frontline regimens. The best regimens induce responses in about 75 to 85% of patients, and somewhere between a third and a half of those responses reach that very good partial response criteria. So our basic treatment algorithm is this. First, somebody is diagnosed with amyloidosis, and we do the mass spectrometry to ask the question, is this AL-type amyloidosis? If it's not, then chemotherapy type treatments like the one we're talking about are not used. If it is, first question we ask is this patient a potential candidate for stem cell transplants? And that's usually a younger, more fit patient, often without advanced heart involvement. And if the answer is yes, we go on to do high-dose melphalan stem cell transplant because it's very effective therapy. Other patients who either opt not to have that therapy or aren't fit enough to get that intensive therapy get some other chemotherapy regimen like the CyBor-D regimen that I recommended. Regardless of what the regimen they start out with is, the question that we ask is, does the patient get a major response? So this slide says light chain remission, but I think most of us accept that if you get at least a very good partial response, that's an adequate response to a particular treatment regimen in AL amyloidosis. The answer, if the answer to this question is no, if we don't get an adequate response, then we consider additional therapy. Sometimes more cycles of the same therapy if we feel we've made some progress, and sometimes moving on to a different second-line regimen. Now, the standard of care after a patient has achieved a maximal response is to start monitoring the patient closely without additional treatment, at least additional treatment aimed at the plasma cells, while we wait and see if the organs start to improve. We also now are entering an era where we have therapies that might be useful in this particular circumstance. And one that I mentioned here is called NEOD-001. So as an introduction to that, I want to sort of update our list of potential agents that we can use and point to a new column that I've added on the far right, which lists antibodies. Now, some antibodies like daratumumab or SAR 650-984, that's actually called isatuximab now. The antibodies like these two here, these actually work by targeting the plasma cells kind of the way chemotherapy does. But these other antibodies, NEOD-001, 11-1F4, and another antibody, usually given with a small molecule drug as well, called anti-SAP antibodies. These actually don't target the plasma cells. These work by a fundamentally different mechanism. They actually target the proteins. Remember, our original therapy choices really all target the plasma cell. By targeting the plasma cells, we reduce this number, and by doing that, we end up reducing the number of light chains, and that hopefully leads to downstream clearance of other products, of other amyloid species. With antibody therapy, though, we actually target these species here, and tagging the proteins with antibodies, just as in your normal immune system when something is coated with antibodies, what it does is it allows your immune system to start cleaning it up and clearing it. And so what we hope will happen by targeting the protein clumps and fibrils with antibodies, it will permit a increased rate and frequency of clearance of these and hopefully lead to more rapid improvement in organ function. So the algorithm slide that I showed you before suggests that after treatment, a good time to think about using these fibril clearing therapies might be when you would otherwise be watching. We're also doing studies right now with NEOD-001 where we're combining it right up front with chemotherapy. So we're simultaneously attacking the plasma cells to choke off production of light chains and downstream amyloidosis, and at the same time starting the cleanup early on to speed those responses along. And there's a randomized study right now of Cybor-D chemotherapy with or without this antibody called NEOD-001. It's called the VITAL study, and that is currently accruing patients at many centers around the country. So it will remain to be seen based on that study and another study looking at patients who've already completed their treatment called the PRONTO study, whether or not NEOD-001 improves the rate of organ responses. I'm going to show you some data to show you why we're hopeful that it will in just a minute. It should be noted this is not the only antibody, as I mentioned before, not the only antibody that targets the fibrils. The 11-1F4 antibody mentioned here is currently in clinical studies at Columbia University in New York, and it's still at an early stage, not at the randomized trial stage, but we are starting to treat patients with multiple doses of this antibody, and there's evidence that it can induce organ responses. And then finally, there's been an antibody that targets something called SAP, which is a constituent of all types of amyloid fibrils. And so anti-SAP antibodies and a partner drug called CPHPC, these together target something that may be present not just on AL fibrils, but all types of amyloid fibrils, and so may have applications not just in AL amyloidosis, but in other types as well. Finally, there are some other therapies, including the antibiotic doxycycline, and the supplement EGCG, which have been touted as antifibril therapies, and I will show you the data that supports that or fails to support it. First, the NEOD-001. This has been studied in a phase 1/2 study, completed now. And the first part of the study looked at 27 patients who were treated at varying doses of the antibody once a month intravenously. And then after that, once it was determined that even the highest doses were well tolerated, there was an expansion phase where not only were all the patients from the initial phase of the trial permitted to have their dose escalated, but another group of patients treated at the highest dose were also accrued. The primary objective of this study was to look at the safety, of course, of these different doses, and also to inform dose selection for future trials. But also, we wanted to see certain things like, how does your body metabolize the antibody? Does your immune system have a reaction against this antibody, this artificial antibody itself? And then we also wanted to get some hint as to whether or not organ function improved, and we evaluated the heart and kidney responses in this trial. And so we saw very interesting results. Normally, about a third of patients treated with chemotherapy will ultimately have improvement in their heart function. And in this particular study, out of over 30 patients treated, the majority of them, just over half of them, actually had more than a 30% reduction in one of their cardiac markers, the NT-proBNP, and this is the definition of a heart response. And even in the patients who didn't quite get to that 30% reduction, a number of patients did have some improvements in heart markers, even if they didn't quite get to the threshold needed to be called responders. Very few patients had a worsening of their cardiac marker, and of those who did, none of them actually met the criteria for progressive heart injury. It should be noted that we did similar types of analysis for kidney function, and when we're analyzing kidney function, what we're looking at is reduction in the spillage of protein in the urine, which is a marker of kidney injury. And when the kidneys are healing, the protein spillage in the urine goes down, and we did see that about half of patients who had protein in the urine had reduction of that. Again, that's in excess of what we would expect if we were just adopting a wait and see what happens approach. So these responses, I think, are really what are, sort of driving the enthusiasm behind the randomized studies that I mentioned before. Now, I'm going to switch gears completely, and we're going to talk about the other common type of amyloidosis, ATTR amyloidosis, or transthyretin amyloidosis. This is a completely different disease. First of all, it's not a plasma cell disease. Transthyretin is made by the liver. It is not made by plasma cells in your bone marrow. And since it's made by your liver, you can't just target the cells that make it with toxic agents the way we use chemotherapy to target plasma cells. There are two different general types of transthyretin amyloidosis. There's familial type, which is caused by a mutation in the transthyretin gene that results in the production of an abnormal transthyretin molecule. And then there are also some patients who develop transthyretin amyloidosis as they get older, and that's called wild type transthyretin amyloidosis, and that's not inherited. It does seem to be, it does become more common as people age. So, transthyretin, normal transthyretin is part of our body system. I'm going to go into a little bit of depth about it just so that you understand our treatment approaches to it. So the liver makes transthyretin. The transthyretin subunits are produced and put into circulation, and they try to cluster into groups of 4 called tetramers. And the groups of 4 are more stable than the single units. And it's the groups of 4 that carry out the normal function of transthyretin, which has to do with vitamin A transport, that's retinol, or thyroxine, which is thyroid hormone transport. Both of these are bound by these transthyretin tetramers and transported within the body. So there's a normal function for transthyretin, and that normal function is carried out by these clusters of 4 subunits called tetramers. Now, in familial transthyretin amyloidosis, you inherit an abnormal gene. So you have one normal transthyretin gene inherited from one parent and one abnormal gene inherited from the other. And what you get is you get production of both normal units and abnormal units, and they don't form tetramers as readily. They do form tetramers, but not as readily as in a normal situation, and so they're more apt to circulate as single units because of that instability. And what happens is the misfolded single subunits, or the misfolded monomers, are what end up being incorporated into amyloid. So there are prefibrils, right? So these, again, sort of like these soluble clumps. And then eventually what happens is you get fibrils. And the fibrils are similar to the AL fibrils, except these subunits are transthyretin instead of light chain, but they do deposit in organs. In transthyretin amyloidosis, the heart and nerves are by far the most common. And to some extent, different types of mutations are associated with different presentations, a higher likelihood of either heart or nerve involvement. And again, remember that not every type of transthyretin amyloidosis quite works this way, because only the types where there's a mutation, the familial types, those are the ones that have mixed deposits that incorporate these mutated or abnormal transthyretin monomers. Wild type transthyretin amyloidosis, the deposits are made up of normal subunits that aren't mutated, but nonetheless do form amyloid. And the reasons for this aren't entirely clear. So I told you about all of this just to help me explain to you our treatment approach to ATTR amyloidosis. As I said, we can't just poison the liver to stop transthyretin production, because we need the liver for everything else that it's doing. So we approach transthyretin amyloid by sort of attacking each of these steps as we're able to. So for starters, there are medications which can actually stabilize the tetramer. So remember I mentioned that when you have the misfolded subunits, tetramers aren't as stable, but in fact there's a medication that's approved in Europe and in Japan called tafamidis, which does stabilize the tetramer. And transthyretin, when it's in the tetramer form, does not get incorporated into the amyloid fibrils. It's only the monomers, only the single subunits that get incorporated into the amyloid. So in a way, it's protective to keep the transthyretin in clumps of 4. In the United States, we don't have tafamidis, but we do have a non-steroidal anti-inflammatory drug called diflunisal, which is able to be used off-label and which does have a similar stabilizing property. Now, we can do something to reduce the production of misfolded subunits. We could do a liver transplant. So liver transplants replace a liver with genes for a mutated transthyretin molecule with a liver that doesn't have that mutation, and thereby only producing normal transthyretin. And we'll talk about the pros and cons of that in a few minutes. But the other things that we do, we can destabilize the amyloid fibrils with doxycycline. That's the antibiotic that is used to treat acne, to treat infections, sometimes to treat rosacea. 1 to 2 tablets a day of that has been shown to have a destabilizing effect on amyloid plaques. And finally, the other thing we can do, remember that I mentioned that one of the antibodies that's currently being studied in AL amyloidosis may also be able to target other types of amyloid, because really what they're targeting is a supporting protein called SAP rather than the subunits themselves. And so even though the main structural protein in AL fibrils is light chains and ATTR fibrils is transthyretin, the SAP is a common thing in both types of fibrils, and that can be targeted with the same antibody. So I want to focus in on liver transplant because it's one of the oldest active therapies in transthyretin amyloidosis. It was really the first disease-modifying therapy. It's only really usable in younger patients and generally is most helpful in patients with early-stage disease. If you start trying to do liver transplants in older patients who have really impaired heart function, there's really a lot of mortality, a lot of fatal complication rates associated with that, and the therapy is not so useful. The other thing, though, that limits our ability to do that is the availability of livers. And so not everybody who's a candidate ends up having access to a liver. The other potential pitfalls of this is that even though you reduce the production of misfolded transthyretin by a lot, you don't reduce it by 100% because there are other areas in the body besides the liver which produce a little bit of it. So that's one issue. But the other one is that once you have seeds of amyloid in the body tissues, normal transthyretin that's made by the new transplanted liver can be incorporated into those fibrils. And so there can be progression of organ injury from further amyloid deposition, albeit more slowly than there would be if you were still producing the misfolded transthyretin molecule. So overall, post-transplant quality of life is highly variable based on all of these factors. So a question which could be asked is there a different way to reduce liver production of transthyretin? We know that we can't give something equivalent to chemotherapy to just poison the whole liver. We know that most patients aren't going to get a liver transplant either because they're not healthy enough to do it or because there's not a liver available. But there actually is a way to address this, and it's with therapy. It's with targeted therapies to reduce misfolded protein production. I want to just review protein synthesis for a quick second to bring everybody up to speed and understand what we're talking about. Protein production is a multi-step process. The genes for a particular protein are in the DNA, and the DNA, when we want to produce a specific protein, the RNA for that particular protein is copied from the DNA, as if from a mold, and then the RNA is used as the template for the actual protein production. Okay, so DNA so RNA is produced by reading the DNA, and proteins are produced by reading the mRNA that's produced. And then once the protein is synthesized, it's synthesized as a chain, and then there are modifications made to it, and it folds. And actually, it's felt that that abnormal folding is one of the factors that contributes to the risk of forming amyloidosis. Now, I'm telling you all about this because I wanted to emphasize that the production of a specific protein is related to things that happen starting with a specific gene in the DNA and the production of a specific RNA. And you can create molecules that actually target or interfere with this the production of a protein by targeting the mRNA or the RNA for that specific protein. So our bodies can naturally do this. We actually have mechanisms within our own cells to sort of regulate the production of proteins through RNA interference. But it's possible to generate drugs, and there's a variety of different ones. And two of the ones we're going to talk about are siRNAs, or small interfering RNAs, and another one called antisense RNAs. And both of these bind specifically to the RNA in the cell. So the cartoon I'm about to show you looks at one of these siRNA. And what you can see here is you have this double-stranded siRNA chain. It gets into the cell, and then the cellular machinery unwinds it, and it unwinds it down to a single strand, and then that strand matches up to the mRNA that you want to inhibit. And by doing that, it leads the cell to sort of break down the mRNA. And because the pattern of the drug we're using can be tailored directly to the sequence of the RNA for a specific protein, it only affects the RNA levels for that specific protein and not for other types of protein. So you can actually get your liver cells, for instance, to stop making transthyretin by targeting the RNA of transthyretin, and you leave the RNAs for other proteins that same liver cell is producing. It leaves those alone, and the cell can keep producing the other proteins. So this is really like a silver bullet. And one drug that we've had the opportunity to be involved with is an siRNA agent called patisiran, which is an intravenous medication. And what I'm showing you here is a graph where a bunch of healthy volunteers were each given a single dose of patisiran IV. And they were treated at different doses, and the yellow, orange, and light blue curves shown here at the bottom are the patients who are treated with the higher doses. And what you can see is that after a single dose of medication, the level of transthyretin in these patients' blood decreased by 80 to 85%. And that decrease lasted for the better part of a month. It was still between 60 and 80% reduced at 30 days after just a single dose. So this kind of study shows that it is possible to knock down the level of transthyretin production with a targeted medication that goes after the RNA for that particular protein. This is similar data from another drug called Ionis TTR-RX. It's a slightly different type of RNA interfering therapy called antisense oligonucleotide. But what we can see here, again, as we saw with the other one, we can see here that a single dose of this medication in healthy volunteers knocks down transthyretin levels, in this case, a 30% reduction in a dose-dependent way. And it's been shown that higher doses can actually decrease the levels further. So both of these studies, both of these agents, patisiran and Ionis TTR-RX, have been in clinical studies.
We're now in the midst of clinical trials utilizing these RNA interference therapies. The next few slides will go over a few of these studies and the status of the development programs. One trial that we've had the opportunity to be involved with at the Karmanos Cancer Institute, along with many other institutions around the country, is the Apollo Phase 3 trial. This is a study for patients with familial ATTR amyloidosis with polyneuropathy. This slide shows the design of the trial. These are for patients with moderate symptoms, and it's a randomized trial with 2 patients randomized to patisiran intravenously every 3 weeks or placebo for 18 months. It's a 2-to-1 randomization, and after 18 months of therapy, all patients are permitted to go on an open-label extension trial. This trial has completed accrual, and we're waiting for a readout of the endpoints. The primary endpoint of the study looks at a neuropathy score called the Modified NIS+7, which looks at various neurologic symptoms and findings, and the neurologic assessments on this study were done at central sites where the investigators were specifically trained to do the analyses. There are also many other endpoints being examined on this study, including a variety of quality of life scales where patients report symptoms that they're experiencing. The same company has a second product, which is a subcutaneous drug called revusiran, and there was a phase 3 trial called the Endeavor study for patients, again, with familial ATTR amyloidosis, but this study was focusing on familial amyloidotic cardiomyopathy or heart involvement. And you can see here the design of the study, again, a 2-to-1 randomization favoring, a 2-to-1 randomization where 2 patients were randomized to revusiran versus placebo. And the endpoints in this study were a bit different. The primary endpoint was a change in something called the 6-minute walk time, which basically looks at a patient's ability to walk measured distance over a 6-minute period of time in a very standardized and rigorous fashion. And then there were secondary endpoints, including a composite endpoint looking at cardiovascular deaths and hospitalizations for cardiac events. This trial was terminated early. There was a phase 2 trial using revusiran in cardiac amyloid patients, and actually there were there was a neuropathy toxicity signal noted in the phase 2 study, and so the safety committee for this particular trial recommended closure of the study. Now, this doesn't affect the Apollo study, which uses a different siRNA product, the intravenous one, patisiran, but it does result in a delay in exploring this type of therapy in cardiomyopathy patients. Likewise, we've recently run into trouble with a cardiomyopathy trial from another company, Ionis. This company has an ongoing study also in polyneuropathy. The design is quite similar to the design of the Apollo study. As you can see here, a 2-to-1 randomization utilizing an antisense RNA product called Ionis TTRRX. This is a weekly subcutaneous injection, and it's being compared to placebo. 15 months of therapy followed by an open label extension where everybody is able to get the actual drug. This study has also completed accrual, and we're waiting for the results of this, and we expect those results sometime in the next year or so. But in the meantime, there was some data regarding this product related to the unexpected occurrence of low platelet counts in a handful of patients. And because of this, there was a decision made to cancel a cardiomyopathy trial until we see the results of the polyneuropathy trial and also get a better handle on this particular signal. So taken together, we have two studies that are going to be looking at outcomes in patients with amyloid-related polyneuropathy. one from Alnylam with patisiran, and the other one with Ionis TTRRX from Ionis. Once we get that signal, we may see further movement utilizing these or similar products in cardiomyopathy patients. There have been some other companies in this area. Arcturus is a company that has done some work with RNA interference therapy in ATTR amyloidosis and in other diseases, and it remains to be determined how that will be moving forward. The other interesting application could be siRNA therapy or RNA interference therapy for AL amyloidosis, because light chain production is also a potentially targetable protein production. The challenge, of course, is that the cells that make light chains are different than the cells that make transthyretin molecules, plasma cells versus liver cells. And so one of the things that we'll need to figure out is how to deliver this therapy to the cells that need to be targeted.
I'm going to close by talking about a couple of other agents very briefly. I mentioned doxycycline before. There's actually preclinical mouse-type data that I'm going to show you here related to that, and then I'm going to share with you what we know clinically so far. So there's a mouse model of amyloidosis that was sort of created at Boston University. And in this model, what happens is by the time a mouse is 3 months old, there's about a 25% chance that they'll be forming amyloid in their stomachs. And if you give them enough time, by 10 months, about 70 or 75% have amyloidosis in their stomachs. And so researchers at Boston University did a trial where they fed some mice in this model normally and gave other mice in this model doxycycline in their water starting at 3 months' time. And what we saw on this trial was that amyloid formation proceeded as normally in the mice that were fed water, but the mice that were fed doxycycline stopped forming amyloid, and that the percentage of mice who had amyloid in their stomach was actually the same at 10 months as it was at 3 months. And in the same paper that described this finding, they looked at the way that doxycycline, or the effect that doxycycline had on established amyloid fibrils in the laboratory, and sort of the stability of those amyloid fibrils in response to different kinds of stress, and showed that it did seem to destabilize amyloid fibrils. And we do have some data from both the Mayo Clinic and from researchers in England suggesting that when you treat cardiac AL amyloid patients with doxycycline, that it may lead to less cardiac complications and a lower rate of cardiac deaths over time. In the Mayo group, the way they showed this was they compared the results of patients who had transplants and had the normal post-transplant antibiotics, which included penicillin, versus patients who went through a transplant but were penicillin allergic, so got doxycycline as an alternative antibiotic. And when they compared the outcomes of those patients, it turns out that the patients who got doxycycline had a significantly better post-transplant course. So that's not the same thing as a randomized study, but it is provocative data. And there's similarly provocative data from Britain. So doxycycline is available by prescription in the United States. It can be difficult on the stomach. It does sensitize the skin to sunlight and can make you more prone to sunburns, but many people are able to tolerate it rather easily. And I think there's an increasing number of patients with cardiac involvement by AL amyloidosis who are getting doxycycline as an adjunctive therapy in addition to the anti-plasma cell therapies or other antifibril therapies that we're using. The other thing that I mentioned before was green tea extract, and the active ingredient is EGCG. The data on this is not very strong. There is some preclinical laboratory type data to show that it seems to have an effect on protein folding, which might be relevant to amyloid formation. But the bulk of the evidence is really case reports, and one of the famous case reports was the case of a doctor, Dr. Hunstein, who after showing symptoms of progressive congestive heart failure following chemotherapy, started drinking copious amounts of green tea, and subsequently was found to have improvement in his cardiac biomarkers and functional status. So his New York Heart Class, which is a measure of the severity of congestive heart failure, improved from advanced to less advanced. And the thickness of the wall of the heart, the IVSD that I showed you a slide of early on, improved from 16.5 millimeters to 12.6 millimeters. Now, the problem with this particular report is that it should be noted that after chemotherapy, the patient actually had a significant improvement in the light chain. This was a case of lambda light chain amyloidosis, and you can see the level of light chains dropped from 73 down to 44, which basically is almost cutting it in half. This is a very nice response, technically a very good partial response, and I already showed you data that patients who achieve a very good partial response are the ones who, or better, are the ones who have improved outcomes. And so 25 months after finishing chemotherapy, having an improvement in heart function when you had a VGPR that was still present after 11 additional months of green tea could be the result of the chemotherapy with a delayed organ response, or could be, in part related to the green tea, or could be both. And so I have a lot of patients who ask me about whether or not green tea extract is a reasonable thing to use when they're being treated for amyloidosis. And my answer is, you probably won't hurt yourself using this, but I don't recommend using it simultaneously with bortezomib, because there may be an interaction between EGCG and bortezomib. So if you're going to use it, it should be used either with other therapy besides bortezomib, or at a time when you would normally be just observing the patient. I do have to admit, I do not have many patients who are taking EGCG, and I certainly don't recommend it. Rather, I permit it if a patient approaches me about it. So at this point, we'll just sort of summarize with some key points. First, to remind you again, tissue deposits made out of misfolded protein fibrils damage the organs, and this is what causes the symptoms of amyloidosis, any type of amyloidosis. The current paradigm of therapy in AL amyloidosis is to target the abnormal plasma cells, and by doing that, you reduce the production of abnormal light chains, and by doing that, you reduce the downstream production of amyloid. Lowering the light chains, though, is the key. So we're killing the plasma cells, but we're doing it to lower the light chain. Right now, we're moving into clinical trials, which are targeting the production, which are targeting the fibrils either through immune therapies or targeting protein production, and that's actually perhaps more relevant in transthyretin amyloidosis than AL amyloidosis, at least the focused protein targeting. And the clinical trials that are ongoing really are the key to getting new drugs approved in these types of amyloidosis.
But with all of these new developments in the field of amyloidosis, we are left with some key questions. First, we learned today that newer chemotherapy regimens increase the hematologic response rates in AL amyloidosis, but one unanswered question is whether or not these will overcome the initial predominantly cardiac risk that we see in patients with advanced heart involvement. The earliest information that we have, the latest information that we have right now suggests that by themselves they may not actually reduce that risk within the first 6 to 12 months, but the jury's out, of course. The next question is, will investigational antifibril therapy, either alone or in combination with chemotherapy, help overcome this one particular problem, which is early deaths and complications related to pre-existing organ damage at the time that therapy began? That remains to be seen, but the studies, one study which may help answer this question, which is the VITAL study, is already actively underway. And finally, the last question that we're left with is, will RNA interference therapies that selectively target protein production, will they be able to be successfully developed for ATTR amyloidosis? We have a couple of companies that have already completed accrual to studies looking at patient populations with polyneuropathy. And if these are positive, I think it opens the door for additional studies looking at other subsets with cardiomyopathy, perhaps, or patients with non-familial ATTR amyloidosis. And the other, important point to make is that if these studies provide proof of principle that patients with one type of amyloidosis can benefit from RNA interference type therapy, it potentially opens up the door for the development of therapies targeting other amyloid-forming proteins and other types of amyloidosis.
Okay, so we do have a lot of questions already, and they some of them overlap. So I just want to answer some of the answer the ones that more than one person has asked. A couple of different people have asked about daratumumab, which is an antibody that targets something called CD38, and it is approved therapy for multiple myeloma. And there were recently some really highly publicized studies where it was combined with chemotherapy drugs, showing that's very successful that way. And the question is it being used in AL amyloidosis? So the short answer is yes. We and others have treated some patients with this. There have been some small published series or case reports. What's out there so far is like a handful of patients treated at a couple of centers, a case report at Mayo Clinic, and what we know is that it can lower light chain levels. As a strategy, it's actually not very different than chemo, because what you're doing is you're targeting the plasma cells. So it's just a different platform for killing plasma cells. Instead of chemotherapy, it's an antibody. What makes it attractive is that antibodies are targeted therapy, so the toxicity is a bit more selective than the toxicities of chemo. So there's a lot of interest in developing this. And then there's another anti-CD38 antibody, which on the slides was called SAR, and followed by a bunch of numbers, but that's now called isatuximab is the actual name of the antibody now. And both of those are going to be studied in AL amyloidosis. Right now, those are both IV medications, and the daratumumab in particular is a all-day infusion. So in people who have congestive heart failure and fluid balance issues, a day-long IV infusion might be difficult. We'll see. There is going to be a subcutaneous version of daratumumab, available in the next few years. Hopefully, it's in clinical development right now, and that would be a nice advance and would make it a lot more convenient for patients with amyloidosis. So that addresses daratumumab. The next questions, there's a few questions about There are a few questions about wild type versus mutated type transthyretin and whether the therapies that we talked about today are appropriate for both. The answer is theoretically any of the therapies that are currently being studied for mutated type transthyretin might be relevant for wild type as well. For instance, patisiran, although the studies that have been done so far have been for patients with mutated transthyretin and neuropathy, there's no reason to think that, we know that wild type transthyretin gets knocked down, and we know that from actually the slide I showed you. The single agent healthy patient study, these weren't patients with mutated transthyretin, these were just normal healthy patients. And we showed that you can knock down normal transthyretin levels. So if you can do that, then patients with wild type transthyretin amyloidosis theoretically could benefit from the therapies as well. Further, there's no reason to think that only heart or only nerve involvement might be able to be improved. If you had a patient with transthyretin who had other organs involved, liver or other organs, you theoretically might be able to slow the production of amyloid in those organs as well. Theoretically, knocking down transthyretin would reduce accumulation of transthyretin containing fibrils in any organ, not just the heart or the nerves. Other questions? One question with regards to doxycycline. The question about doxycycline was, is it ever used for wild-type transthyretin? It's kind of the same story as the patisiran. It's actually even a little bit broader than that, because there's actually evidence about the effects of doxycycline in transthyretin amyloidosis and in AL amyloidosis. Remember, I showed you, I introduced the subject of doxycycline when we were talking about transthyretin amyloid, but the mouse model I showed you was AL amyloid, and all the preclinical work that was done there also was related to that. So we do have evidence that both types of amyloidosis and more than just mutated type transthyretin could theoretically be helped by using doxycycline. Let's see. Well, there's a lot of studies, a lot of questions coming in. Let's see. One question has to do with one that just came in about organ transplant. And the question is a heart transplant a viable option for AL with cardiac involvement? So the short answer is maybe. So we talked about liver transplant as a way of knocking down transthyretin production. The reason to do a liver transplant is to sort of shut down the abnormal factory and replace it with a liver that's making normal transthyretin. But the rationale for a heart transplant in any type of amyloidosis is basically to replace the severely damaged heart with a non-damaged heart. And there's also kidney transplant is another question that often comes up. Yeah, I mean, patients with AL amyloidosis can sometimes have organ transplants. I've heard of cases, we have not, at Karmanos, we haven't done this, but there are cases out in Boston and at Mayo of patients who got a heart transplant to make them healthy enough to get high-dose chemotherapy and a stem cell transplant. So that's one order you could do things in. But another question that commonly comes up is, after a patient has had a remission from chemotherapy or some other type of therapy, in terms of the light chains, can you then think about a kidney biopsy to replace the permanently damaged kidneys? And we have several patients actually who have pursued that option, and that's also commonly done. Kidney transplant before treatment is not as common because you don't need new kidneys to survive and get treatment because you're able to be on dialysis. So although other organ transplant does happen, heart transplant is typically the one that happens before treatment in an occasional patient. Somebody asked about a few people have. I'm getting some comments emailed in now about people who are on the line who have had organ transplants. One person wrote, as a heart and liver transplant recipient 8 years ago for ATTR amyloidosis, I have developed post-transplant neuropathy in the feet and fingers and was not diagnosed pre-transplant. Would I be a candidate for any of the new therapies? That is a hard question. So in terms of the off-label drugs like doxycycline, you might be a candidate for that. In terms of patisiran, I don't know. Presumably you had a mutated form at the beginning and got the liver of somebody without a mutation and have developed some additional amyloid, presumably because there are still small amounts of abnormal transthyretin being made in other organs, and normal transthyretin is probably being incorporated into amyloid fibrils too. That's one of the complications. And I guess one would need to ask the sponsor, since the therapies up to this point have been for patients with mutated type and your liver has been replaced. I guess the short answer is I don't know, definitely worth asking about, because patisiran may remain available in clinical studies until we have the readout of that study and have sorted out some of the toxicities. So I would encourage you to speak with your physician about being seen at a site where patisiran's been developed.
And Dr. Zonder, unfortunately, the clock is unrelenting. We may have come to the point where we may move on to any closing thoughts, rather, you might have before I wrap up today's program.
Well, what I would say is this: there are a lot of additional questions that came in, including a lot just in the last few minutes. I'll work with the Amyloidosis Foundation to see if there is some mechanism to answer these questions, and I'll try to get back to people. That there are a lot. There are at least 20 to 30 questions now, so I'm not promising a response this afternoon, but this was. But I'm happy to see you guys engaged. I'm thrilled to see that at one point, although a few people have dropped off, at one point there were over 180 people logged in, which means the Amyloidosis Foundation is really reaching people, and very happy that we're able to provide this information to everybody. Thanks so much.
All right, and thank you, Dr. Zonder. On behalf of the Amyloidosis Foundation, I'd like to thank you for your participation in today's event. Post-event survey will appear requesting your feedback. Please take a moment to complete this survey, as it will help the Amyloidosis Foundation plan future web events. This concludes today's program. Thank you, and have a great rest of your day.